Assalamu alaikum wa rahmatullah. This talk is about updating sepsis and septic shock. Uh, Today, as you know, sepsis is a suspected infection in presence of organ dysfunction. Recent definition states that sepsis is defined as life-threatening organ dysfunction due to dysregulated host response to infection, while organ dysfunction is defined as increase in sepsis organ failure assessment SOVA score at least 2 points need to diagnose sepsis. This is sequential organ failure assessment score or SOVA score. So the next question is, how do you identify sepsis patient? In the recent history, the quick SOVA was represent the best screening tool to identify patient with sepsis. And this quick SOVA include Glasgow Coma score less than 15, respiratory rate more than 22 breaths per minute, and blood pressure, systolic blood pressure less than 100 millimeter mercury. According to last surviving sepsis campaign, it recommends against use of quick SOVA as a single screening tool for identification of sepsis. So beside the quick SOVA score, addition of other scores such as systemic inflammatory response syndrome score or national early warning score and modified early warning score included to identify sepsis patient. In this case, for example, combination of systemic inflammatory response syndrome score with quick SOVA score is used to identify this sepsis patient. You receive a patient with confusion, GCS 13, fever, temperature was 39, and shortness of breath, respiratory rate 30 per minute, with hypotension, systolic blood pressure 90. You diagnose him with sepsis by quick SOVA score and systemic inflammatory response score, syndrome score. So what is your approach to manage patient with sepsis? In general, following ABCD approach, keep airway patent and ensure intact breathing, and introduce 2 large cannula immediately. According to protocol provided by surviving sepsis campaign, last protocol, our 1 bundle should be applied. This patient should be managed by our 1 bundle protocol of surviving sepsis campaign. Our 1 bundle include 2 things take from the patient, which is blood culture and serum lactate, and 2 things given to the patient, which is intravenous crystalloid fluids and intravenous antibiotics. Blood culture should obtained for bacterial and fungal before giving intravenous antibiotic. Also, it should be supported by culture from other media such as sputum or cerebrospinal fluid or urine or tissue or serous fluid from joints according to the suspected source of sepsis. In serum lactate, the goal is normalization of lactate, that is lactate clearance is used as a marker of improving tissue perfusion and is a target of early therapy. Early improvement of at least 10 to 20% from baseline lactate is associated with mortality benefit comparable to mixed oxygen venous saturation of 70% or more. Lactate alone is neither sensitive nor specific enough to rule in or rule out the diagnosis on its own, and the presence of an elevated or normal lactate level is significantly increase or decrease likelihood of final diagnosis of sepsis in patient with suspected sepsis. Measurement of lactate is recommended according to surviving sepsis campaign in the first with blood culture and at the end of resuscitation bolus. In fluid resuscitation, its recommendation is considered as a best practice, and there is no new data suggest that change is needed up to now. So I still recommend to give immediately minimum 30 ml per kg ideal body weight of normal saline or any other crystalloid fluid over 1 hour, according to surviving sepsis campaign. And in this case, fluid have been given over 40 minutes. Failure to receive 30 ml per kg of crystalloid fluid therapy within 3 hours of sepsis onset was associated with increase of in-hospital mortality, also associated with delayed resolution of hypotension and increased length of stay in ICU, and irrespective of comorbidities including end-stage kidney disease and heart failure. Fluid resuscitation monitoring guide during hour 1 bundle. Back to the case, at the end of complete amount of 30 ml per kg of fluid within 1 hour bundle measure, according to last surviving sepsis campaign recommendation, fluid resuscitation monitoring by repeat serum lactate measuring and doing passive leg raising test, measure cardiac output through the first 60 to 90 seconds and assess capillary refill time. This measure in low resource area. Also, stroke volume variation and pulse pressure variation are recommended if available. Is achieved using dynamic measurement, which have demonstrated better diagnostic accuracy at predicting fluid responsiveness in compared with static technique. Study showing dynamic measure assessment to guide fluid therapy was associated with reduced mortality and length in ICU and duration of mechanical ventilation. Back to the case. Your patient now complete 30 ml per kg normal saline fluid over 45 minutes. Dynamic parameters of responsiveness have been established. Passive leg raising test show adequate resuscitation and capillary refill time test show normal refill time, while serum lactate still above 40 millimole per liter, mean arterial pressure still less than 65 millimeter mercury. So this is septic shock. Septic shock defined as sepsis with persistent hypotension requiring vasopressor to maintain MAB above 65 millimeter mercury and blood lactate above 2 millimole per liter despite adequate volume resuscitation. Surviving sepsis campaign recommend initiation of vasopressor to target MAB 65 millimeter mercury or above. Therefore, start vasopressor, which is noradrenaline infusion, if MAB less than 65 after complete resuscitation with 30 ml per kg of normal saline crystalloid. This is a table of outline use of vasopressor in septic shock, as noradrenaline is the first line. If central axis is not available, consider initiation of vasopressor peripherally, and if MAB is inadequate despite of low to moderate dose of norepinephrine, consider addition of vasopressin. Targeting MAB 65 or above, and start invasive monitoring immediately. If cardiac dysfunction with persistent hypotension is present despite adequate volume status and blood pressure, consider adding dobutamine or switching to epinephrine. Patients with sepsis and septic shock who recommend intravenous vasopressor should be admitted to the ICU within first 6 hours of presentation, according to last surviving sepsis campaign. Before starting antibiotic, you have to ensure adequate source control, which include 4 Ds. The first D is device removal or replaced by new one, like central line. Second D is drainage for abscess or any pus, and third D is daily dressing for any infected wound. D is debridement for any dead tissue or gangrene. Surviving sepsis campaign declares that any patient of septic shock or very high likelihood of sepsis should receive antimicrobial treatment within the first hour of presentation. And if patient is highly likelihood of sepsis or possible sepsis without shock, reassessment by physical examination and history within first 3 hours from presentation before starting antimicrobial treatment. In this case, start antimicrobial immediately after taking 2 sets of blood culture with a culture from other potential source such as urine or sputum or else. Studies show early administration of appropriate antimicrobial is one of the most effective interventions to reduce mortality in patients with sepsis. If possibility of patient sepsis is less likely and patient has no shock, defer or postpone the antimicrobial treatment up to first 3 hours of presentation until rapid assessment ruled in or ruled out the sepsis. Balanced against the potential harm associated with administering unnecessary antimicrobial to the patient without infection, like hypersensitivity reaction or kidney injury or thrombocytopenia or Clostridium difficile infection or antimicrobial resistance can be occur. So finally, this is timetable and showing summary of antimicrobial treatment time in sepsis. Same talk, is sepsis definite or possible? So it is likely immediate administration of antimicrobial within first hour of recognition. In 2 cases, if shock present or absent. If shock is possible, but with shock present, also administer of antimicrobial treatment immediately within the first hour of recognition. And if shock not present, rapid assessment of infection versus non-infectious cause of acute illness, and this assessment should be within first 3 hours of presentation, and if proof sepsis, administer immediately antimicrobial treatment. A lot of studies estimated that each hour treatment including fluid and antimicrobial delay is associated with 7 to 10% increase in sepsis related mortality. Surviving sepsis campaign declare that any adult with sepsis or septic shock at high risk of methicillin resistant staph aureus recommend using empirical antimicrobial with MRSA coverage over using antimicrobial without MRSA covering. An adult patient with septic or septic shock with low risk of MRSA resistant surviving sepsis campaign suggest against using empirical antimicrobial with coverage to MRSA. Also, surviving sepsis campaign declare that adult patient with sepsis and septic shock with high risk of multi-drug resistant organism suggest using 2 antimicrobial with gram-negative coverage for empirical treatment over 1 gram-negative agent. And in adult sepsis and septic shock with low risk of MDR organism suggest against using of 2 gram-negative antimicrobial agent, pairing with 1 agent of gram-negative coverage. And adult patient of sepsis or septic shock with unknown causative pathogen recommend against use of double antimicrobial for gram-negative coverage. About fungal sepsis, surviving sepsis campaign recommend that patient with sepsis or septic shock at high risk of fungal infection suggest using empirical antifungal treatment versus same recommendation in patient with sepsis and septic shock with low risk of fungal infection suggest against use of empirical antifungal therapy. Because fungal culture takes from 4 to 6 weeks, therefore addition of other tests is advised. These tests like serum galactomannan or 1,3-BD-glucan, these are 2 biomarkers that used to diagnose invasive fungal infection. Also, antigen antibodies for fungal infection or PCR testing are used when tissue culture are inconclusive or unavailable at the time of presentation. Awareness of fungal sepsis in ICU should be raised due to multiple risk factors. And for example, risk factor for candida sepsis or candida colonization at multiple sites or neutropenia and immunosuppression or severity of the illness according to Apache score, and longer stay in ICU. Also, total parenteral nutrition or broad spectrum antibiotic for prolonged period, and risk factor for endemic yeast, which are available in ICU media like antigen markers such as cryptococcal or histoplasma or blastomyces, and in HIV patient and or after organ transplantation, and patient receiving corticosteroid for long time, and patient with uncontrolled diabetes. Also, risk factor for invasive mouth infection like neutropenia, high dose steroid or solid organ transplantation. If viral sepsis suspected, you do viral screening by ELISA or PCR, but Surviving Sepsis campaign doesn't recommend empirical antiviral treatment. For adult patients with sepsis or septic shock with an antimicrobial treatment, Surviving Sepsis campaign recommend shortening duration of antimicrobial treatment by measuring procalcitonin level to help in adjust the treatment period. Also, many studies showing that there is mortality benefit related to procalcitonin guidance of antibiotic treatment. Also, studies showing other biomarkers for diagnosis of sepsis and prognosis, like mid-region fragment of pro-adrenomedulin, which help to do discrimination of survivor and non-survival and identification of patient with high likelihood of further disease progression. It also acts as organ dysfunction biomarker. Another biomarker is pre-sepsin, which used to diagnose sepsis risk stratification, and it is a potential marker to distinguish gram-positive and gram-negative bacterial infection. Also, one of the biomarkers is soluble STREM1. This is sepsis indicator and used for prediction of septic shock. Last biomarker is pancreatic stone protein, which used to identification of sepsis and as prognostic tool. Surviving Sepsis campaign recommend to add steroid, which is hydrocortisone intravenously on dose of 50 mg 6 hourly when ongoing norepinephrine or epinephrine dose become more than 0.25 mic per kg per minute at least within or after 4 hours from initiation. Also, it recommends to keep random blood glucose from 140 up to 180 mg per deciliter, and to start insulin therapy if random blood sugar more than 180 mg per deciliter. Also, intravenous vitamin C is not recommended to be given in case of sepsis or septic shock. About blood transfusion, Surviving Sepsis campaign recommend to transfuse red blood cell if hemoglobin concentration less than 7 gram per deciliter. However, red blood cell transfusion should not guided by hemoglobin concentration alone. So, assessment of patient overall clinical status and consideration of other comorbidities such as myocardial ischemia or hypoxemia or acute hemorrhage is required. Surviving Sepsis campaign also required venous thromboembolic prophylaxis and such as low molecular weight heparin or physical measures such as elastic stocks, and stress ulcer prophylaxis with proton pump inhibitor like Bantudac or omeprazole. Consider early enteral nutrition within first 72 hours of presentation, and consider renal replacement therapy, conventional or continuous renal replacement therapy within 48 hours if stage 3 acute kidney disease and septic shock, hypoperfusion induced lactic acidosis in serum lactate more than 4 millimole per liter and pH less than 7.15 on vasopressor. Finally, this is sepsis summary. and this is a very important slide, summarized as outline of 7 items, starting by diagnosis of and screening of sepsis. Use Quicksilver with one of the other score like systemic inflammatory response syndrome score, or national early warning score, or modified early warning score. Second thing is apply our one bundle immediately by taking 2 sets of blood culture and 1+1 culture from potential infected site. Measure serum lactate and repeat it after fluid resuscitation. Give minimum 30 ml per kg of crystalloid fluid, normal saline or linger lactate within the first hour of presentation, and start empirical antimicrobial therapy immediately. Also start noradrenaline infusion if mean arterial pressure less than 65 mm mercury after fluid volume resuscitation. Number 3, use dynamic monitoring like passive leg raising test or echo, or other invasive parameters such as stroke volume variation or pulse pressure variation during and after resuscitation of fluid. Also, if duration of antibiotic takes more than 1 week, use measurement of serum procalcitonin to guide and shortening the antibiotic course. Number 5, if mean arterial pressure less than 65 mm mercury after ongoing intravenous infusion of noradrenaline, use reach 0.5 mic per kg per minute, add vasopressin or dobutamine if cardiac dysfunction with ejection fraction less than 35, and add intravenous hydrocortisone 200 mg per day. Number 6, early hemodialysis within less than 48 hours from presentation if stage 3 AKI with septic shock, hypoperfusion, induced lactic acidosis with lactate more than 4 millimole per liter and pH less than 7.15 on vasopressor. Finally, general ICU measures like keep random blood sugar 140 over 180 mg per deciliter, and venous thromboembolic prophylaxis. Use low molecular weight heparin or mechanical prophylaxis like elastic stockings. Stress ulcer prophylaxis. Use proton pump inhibitor, and early enteral feeding within first 72 hours from presentation, and early mobilization and physiotherapy. Thank you to listening and watching this video. Hope it is brief.